Hi everyone, I'm Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are focused, structured and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we are going to break down the anatomy of hip joint into clear, high-yielding exam-focused concepts. So let's get started. Now, hip joint is the largest ball and socket joint in our body. It's a ball and socket type of synovial joint. So this hip joint's mainly function is to support our body when we are standing, as well as it transmits the body weight. Transmits the body weight to the head and neck. To the head. This is the head of the femur, and to the neck of the femur. It transmits the body weight. So it is a multi-axial joint because it allows movements in all the directions. There is flexion, there is extension, there is rotation, medial and lateral rotation, there is adduction, abduction and circumflexion. So all the types of movements are there, but the range of movement is restricted because because it has to maintain our balance during the standing position. Now let's see the articular surfaces. Whenever we say a joint, we have to know the articular surfaces. So the articular surface of the hip joint is formed by the head of the femur. So the entire head of the femur except for one portion. So this is known as the fovea centralis, where the ligamentum teres, or the ligament of the head of the femur is attached. So this head is covered by the articular cartilage except at this point, that is the fovea centralis, where that portion it doesn't articulate. Rest of the entire head of the femur articulates with the acetabulum. So this is the acetabulum of the hip joint. So the acetabulum of the hip joint here will have three parts. So this is the lunate surface. So this is the lunate, horseshoe shaped lunate articular surface. So only this part articulates. Then it will have the acetabular notch and the fossa, acetabular fossa. This is the acetabular fossa, which contains small amount of fat. And here we will have the transverse acetabular ligament. This is the transverse acetabular ligament. So these are these structures which we see along the articular surface of the hip joint. Next, moving on to the ligaments. So for any joint, the ligaments form the important support and they give the stability to a joint. So the hip joint, the first is the joint capsule. So the joint capsule or the capsular ligament here, it is very strong and dense, and it's a fibrous sac which encloses the joint. So here on the hip bone, so on the hip bone, it is attached about 5 to 6 millimeters on beyond the acetabular labrum. So acetabular labrum is the fibrocartilage which we see on the outside of the articular surface, so which will increase the depth for the articulation. So this capsular ligament will be attached on about 5 to 6 millimeters beyond that acetabular labrum. And on the femur here, you can see it is attached anteriorly, to the intertrochanteric line. This is the intertrochanteric line here. So it will be attached, and posteriorly here it is attached to the intertrochanteric crest. So this is the posterior surface, whereas this is the anterior surface of the femur. So the capsule is thicker anterosuperiorly, whereas posterior-inferiorly it is thin and it is loosely attached there. So this capsule, it is made up of two types of fibers. So inner circular, whereas the outer longitudinal. And these inner circular fibers, they form a collar around the neck here, femoral neck. and that is called as zona orbicularis. Okay, so the zona orbicularis is nothing but the circular layer of this capsule, okay, which will be enclosing the neck. The outer longitudinal fibers here will be reflected along the neck, okay, along the neck towards the head, and they form the retinacula. So here the synovial membrane, here you can see, so this is the retinacular fibers here, you can see of the capsule. Okay, so lining this, okay, so here you can see this is the synovial membrane. And here this is this portion here and here, this will be the zona orbicularis, which is nothing but the circular layer of the zona orbicularis. And here we will have the transverse acetabular ligament. This is the transverse acetabular ligament, and this is the ligament of the head. Ligament of the head, which is otherwise also called as the round ligament of the head or ligamentum teres. So here this is the synovial membrane which lines the capsule of the joint. So it lines the inner aspect of the fibrous capsule as well as the intercapsular portion of the femoral neck, the acetabular labrum, okay, both the surfaces here, the acetabular, this is the transverse acetabular ligament, you can see it is lining, then the ligamentum teres as well as the fat here in the among the articular surfaces, or it lines all these things, okay. So synovial membrane lines inner aspect of the fibrous capsule, the intracapsular portion of the, okay, it lines the inner aspect of the fibrous capsule, the intracapsular portion of the neck, the transverse acetabular ligament, the ligamentum teres, then the acetabular fat as well as the acetabular, that is the lunate articular surface. So it lines all of this. So it is thinner on the deeper surface of the iliofemoral ligament where it will be compressed against the head. Next, let's move on to the ligaments. So first coming to the iliofemoral ligament. So the iliofemoral ligament, it is the strongest ligament of the body. Okay, so remember, iliofemoral ligament is the strongest ligament of the body, and it prevents, okay, our trunk from falling backwards when we stand. Okay, it prevents from falling, so that strong it is. So here if you see, this is the iliofemoral ligament. Okay, this is the iliofemoral ligament, and it is in a inverted Y shaped. Okay, it's inverted Y shaped. So here this ligament consists of three parts. So if you see, there are three parts here. So the first part here, it is lateral and it is thick. The fibers are arranged obliquely here. Okay, so it's lateral, thick and oblique fibers. Then there is a medial. So these fibers are medial, thick and vertical. And in between here the central portion is thin. Okay, so it's a large, thin central portion. So these, okay, so this is the central large thin portion. So these three forms a part of the iliofemoral ligament, which is the strongest ligament in our body. Next we have the pubofemoral. So this is the pubofemoral ligament. Okay, so this is the pubofemoral ligament. So this ligament, it is a triangular ligament where the base is attached above here and the apex below. Then here there is a portion marked. This is just here you have to know that it is the site of communication of the 𝗧𝗏𝗔𝗟. 𝗧𝗏𝗔𝗟 communicates here. 𝗧𝗏𝗔𝗟 will be between the psoas muscle as well as the neck of the femur. So that is where it will be present and will be communicating with the joint capsule there. Then coming to the next ligaments after iliofemoral and pubofemoral, we have, so here also we can see the oblique fibers of the iliofemoral ligament behind, and we have the ischiofemoral, that is coming from the ischium. Okay, so this is the ilium and this is the ischial portion. Okay, so this is ilium here, whereas this is the ischium. So coming from here we have the ischiofemoral ligament. Okay, so here we have this ischiofemoral ligament, and here we can see the oblique fibers of the iliofemoral, that is the oblique part of the iliofemoral ligament. So all these ligaments, that is the ischiofemoral, the iliofemoral and the pubofemoral ligaments, they provide the main support or stability to the hip joint. Then we have in the hip bone, we have the acetabular labrum. So this is the acetabular labrum. Acetabular labrum, which is nothing but the fibrocartilage. Okay, so it is a fibrocartilaginous rim which is attached to the acetabular margin. So this basically deepens the acetabulum socket so as to grasp the head of the femur. Then here we have the transverse acetabular ligament. So this ligament here, as you can see, it bridges the gap, here bridges the acetabular notch. So this ligament, it is devoid of any cartilaginous cells. Now, and this because of this ligament also, this acetabular notch gets converted to a foramen, and this foramen will be transmitting the acetabular branches, that is branches of vessels and nerves to the hip joint. Then we have here, you can see, this is the ligament, round ligament of the head of the femur, or it is also called round ligament of, or ligament of head of the femur, or called as the ligamentum teres. Okay, ligamentum teres. So this ligament doesn't provide as such any support, but it transmits, transmits arteries to the head of the femur. So basically it is for the transmission of, it transmits arteries to the head of the, femur. So these are the main ligaments which provide stability to the joint. Then next you need to know some of the bursa around the hip joint. So bursa around the hip joint, we have 7 bursa. Okay, so 4 are present under the gluteus maximus, 4 under gluteus maximus, and 1 under gluteus medius, and 1 under gluteus minimus, and 1 under psoas major tendon. Psoas major. Okay, so we have like this 7 ligaments. Okay, so the ligaments beneath the gluteus maximus, we have between the gluteus maximus. So here we can see some of them. Okay, 2 of them we can see here. So one is between the gluteus maximus and the ischial tuberosity. Okay, the gluteus maximus and the ischial tuberosity. And when this bursa is inflamed, especially in people who sit for a very long time, like in the weavers, okay, it results in the inflammation, and that is why it is called as the weaver's bottom. So that is between the gluteus maximus and the ischial tuberosity. Then we have between the gluteus maximus and the greater trochanter, and gluteus maximus and the, so this is between the gluteus maximus, here between gluteus maximus and greater trochanter, gluteus maximus and the ischial tuberosity, then gluteus maximus and the vastus lateralis, as well as gluteus maximus and the ilium. So these are the four sides. Okay, so between gluteus maximus and ischial tuberosity, then between gluteus maximus and greater trochanter, then gluteus maximus and which one? The ilium, and gluteus maximus and vastus lateralis. Okay, so we can see here two. This is the largest one among the bursas. Okay, and this is the one between the vastus lateralis and gluteus. So the one between gluteus maximus and ischial tuberosity is more prone for inflammation, and that results in Weaver's bottom. Then here we can see this is the gluteus medius muscle. Here this is the medius muscle. So this is the bursa between the gluteus medius and the lateral part of the greater trochanter. Then we have between the gluteus minimus, this is the minimus, this is the bursa here we can see beneath the gluteus minimus and the greater anterior aspect of greater trochanter. Then here we can see this is the psoas tendon, okay, and this is the subpsoas bursa here. This is called the subpsoas bursa. Okay. So this is between the iliopubic. So this is the iliopubic eminence and the psoas tendon. So here we can see the subpsoas bursa. So in 10% of the individuals, this psoas bursa, I had shown previously the site of communication. So it communicates with the synovial cavity of the hip joint. So that communication is mainly between the 𝗕𝗵𝗄𝗏 and iliofemoral ligaments. Okay. So coming to the movements of the hip joint. So the movements of the hip joint, since it is a multi-axial joint, takes place in all the directions except that the range of movements is restricted. So the maximum movement occurs along the flexion, that is about 110 to 120 degree movement happens along flexion. So we have the the different movements occurring along the hip joint is flexion and extension. So the flexion is mainly brought about by the psoas muscle as well as the iliacus muscle. So they are the chief flexors, which are again assisted. Okay, the accessory muscles will be the sartorius, rectus femoris and pectineus. Whereas the extension is mainly brought about by the gluteus maximus. Gluteus maximus is the chief extensor of the hip joint. Then we have the adduction and abduction. So adduction movement is brought about by the adductors. Okay, the mainly adductors, we have the adductor longus, adductor brevis and the adductor magnus. So these three muscles, they bring about the adduction along with pectineus and gracilis also. And then we have the abduction. So abduction is brought about by the gluteus minimus and the medius muscle. Then the next movement we have the medial and lateral rotation. So here the flexion I told you takes place in the range of 110 to 120 degree, whereas extension is just 15 degree. Abduction is about 50 degree and medial rotation is about 25 and lateral rotation is about 60 degree. So this in this range the movements takes place. Okay. So medial and lateral root. So medial rotators here are basically the anterior fibers of the gluteus. Medial rotation will be by the gluteus minimus and the medius, which are the chief medial rotators, along with tensor fascia lata. The lateral rotators are mainly the piriformis. Piriformis brings about lateral rotation, obturator externus, obturator internus, okay, along with the gemelli muscles. So they are basically a short, we call them as the short rotators. Then a combination of all of these movements will be the circumduction movement. So these are the movements taking place around the hip joint. Next, let's move on to the arterial supply of the head of the femur. So mainly here the hip joint is mainly supplied by the branches of medial circumflex femoral artery, the lateral circumflex femoral artery, obturator artery, superior gluteal and the inferior gluteal. Okay. So mainly it is derived from three sources, though all these arteries supply around the hip joint. There are three main sources. One is the acetabular branches of obturator artery and medial circumflex femoral artery. Okay, so these mainly femoral artery. Okay, so the acetabular branches. So these supply basically the head of the head. These arteries, they pass through the round ligament of the head of the femur and they supply. Then we have the reticular branches. Okay, so this is first one. Then we have the reticular branches, reticular vessels or reticular branches, which arise again from the medial circumflex femoral artery. Okay, so this one, and they run along. So here you can see these are the reticular branches here, and here we will see the acetabular branches. Okay, so these reticular vessels, they are the main source, okay, which arise from the medial circumflex. So medial circumflex will be around here. So from this we have the reticular branches which arise and they form the main source of supply, which run along the neck of the femur, okay, through the retinaculum of the capsule. So retinaculum of the capsule, when we say, it is the longitudinal fibers of the capsule. Okay, so we have the circular layer and the longitudinal layer. Circular layer we call it as the zona orbicularis, whereas the longitudinal layer we call it as the retinaculum. Then we have the nutrient artery. So these were the reticular arteries, and we have the nutrient artery here. So nutrient artery of the femur, it gives branches to the head and neck of the femur. So that is these are the arteries, these are the three main sources which supply the hip joint. The nerve supply for this joint is by the femoral nerve through the nerve to rectus femoris. A branch from the anterior division of the obturator nerve also supplies. Okay, and nerve to quadratus femoris, then superior gluteal nerve, and also sometimes from the sciatic nerve also supplies the hip joint. Next, let's see some of the clinical aspects of the hip joint. So there is congenital dislocation of the hip joint. So congenital dislocation of the hip joint is the most common than any other dislocations in the body. Okay, so this is mainly due to two reasons. So we have two reasons. So I said it is the common, okay, is more common than any other joint. So congenital dislocation. So one is, the reason being, the capsule, the joint capsule will be very loose at the time of birth because the bones are not yet ossified there. So it will be loose at birth, one thing. Then second thing is there is hypoplasia. Hypoplasia of the acetabulum acetabulum and femoral head. Okay, so hypoplasia of the acetabulum and the femoral head also causes. So these two are the main reasons. So clinically what happens, there is inability to abduct. The newborn is unable to abduct the thigh. And the affected limb, if you see, the affected limb will be shorter in length and will be externally rotated. Okay, so shorter and externally rotated. And the skin over that region will be asymmetrical, that is when you compare on both the sides. Okay, so in the skin folds will be asymmetrical, and when the child starts walking, there will be lurching gait with positive Trendelenburg's sign. So what do we mean by Trendelenburg sign? So normally what happens while we are walking, when the foot is off the ground, the gluteus medius and minimus, they will support of the opposite side, they support without us falling sidewards. But when there is paralysis of these gluteus medius and minimus, okay, gluteus medius and minimus, which is mainly supplied by the superior gluteal nerve there, okay, so it results in the hip sagging towards the healthier side. The next common condition which we see in the hip joint is the fracture of the hip joint. So fracture of the hip joint, when we generally say, it basically implies the fracture of the neck of the femur. So there are 4 types of fracture which we see mainly. One is the subcapital. This is the subcapital fracture, that is which occurs near the head. Then we have the cervical in the middle, cervical fracture, that is in the neck. Then we have the basal near the trochanter's, basal fracture, and pretrochanteric, that is before the trochanter's. Pretrochanteric fracture. So this is below the the trochanter. So these are the 4 types of fractures which occur around the head and neck of the femur. So we will see the involvement of the arteries in these fractures which supply the arteries which supply the head of the femur. So depending upon the type of fracture, there will be involvement of the reticular, that is the retinacular arteries. So retinacular arteries, they are the main source of supply to the head and neck of the femur. And retinacular arteries, they arise from which artery? They arise from the medial circumflex humeral artery. Okay, medial circumflex humeral artery. So here in extracapsular, okay, extracapsular. Now pretrochanteric fracture is extracapsular. So before the retinaculum of the, and when we say retinaculum, they are nothing but the longitudinal arrangement of the capsule, longitudinal fiber arrangement of the capsule, outer longitudinal fibers. So this retinacular arteries, they pass through this retinaculum, right? So before the, like if this is the pretrochanteric fracture, so retinaculum will be along the intertrochanteric line here. Okay, so here what happens in this extracapsular, this pretrochanteric fracture will be outside the capsule of the joint. So that is why this will not involve the vessels. This fracture will not involve the vessels. Which vessels? The retinacular vessels. Because this is very important, because depending upon the type of fracture and involvement of the retinacular vessels, there is chances of aseptic necrosis of the head of the femur. So where will the retinacular vessels then will be involved? When it is a intracapsular subcapital fracture. So here there is, see here the retinacular vessels are involved. So there is interruption to the blood supply to the head, and that results in aseptic vascular necrosis. of the head of the femur. Now let's see some of the MCQs. So AP X-ray of pelvis shows disruption of a smooth curved line along the inferior border of superior pubic ramus and neck of femur. The disrupted line in the image represents. Okay. So usually in the X-ray we see for two lines. One is the Shenton's line and is the Skill-Maker's line. So Shenton's line here is the smooth line which we see along the upper margin of the obturator foramen and along the neck of the femur. So this should be a smooth line when we see. So usually this line is disrupted in case of fracture or dislocation of the hip joint. So the answer is Shenton's line. Zona orbicularis, we know it is the circular arrangement of the capsule, circular arrangement of the fibers, that is the inner layer of the fibrous capsule. The ligaments, they are not involved here. MRI showing a crescent-shaped subcondylar lucency in femoral head. So usually the subcondylar lucency in femoral head, we can see a fracture here. So there is a fracture. So fracture is there and there is a subcondylar lucency there. So that is basically in MRI when we see like that, it is nothing but avascular necrosis. Okay, so the answer is B. Labeled diagram showing retinacular arteries, artery of ligamentum teres, circumflex femoral arteries. Question in an adult, the main blood supply to femoral head is from. Okay, so we learned that the retinacular arteries as well as the acetabular arteries, okay, branches, they are all branches mainly of the medial circumflex femoral artery. Obturator artery gives 2, but mainly it is from medial circumflex femoral artery. So this artery gives both retinacular as well as the acetabular arteries. So the right choice will be medial circumflex femoral artery. Patient with flexed hip, adducted, internally rotated limb. Most likely diagnosis. So here we can see there is flexion of the hip, there is adduction and there is internal rotation. So this happens in posterior, typical posterior hip dislocation. In an X-ray showing Trendelenburg gait, the damage showing. So this basically is the X-ray of the person with the Trendelenburg gait, and we have learned that Trendelenburg gait is basically due to positive Trendelenburg